Okay, hello everyone. Today we're going to be covering chapter 2 from your mammography preparation and examination book. The chapter is titled Patient Education and Assessment. Okay, so first, there's a need for effective patient interaction. Mammography is a very sensitive exam. It is important that our patients feel comfortable, that they feel well taken care of, and that we maintain positive and effective communication. So, mammography is a orientated, hands-on profession. Population of American is diverse, right? We know that we are a melting pot of cultures and types of people. Patient cooperation and compliance is very, very important. The more your patient feels comfortable and can aid in the examination, the smoother it will go. And hospitals and clinics depend on reimbursement for the exams that we provide in mammography. So, communication, the key to an effective interaction. So, this is going to include before the exam, during the examination when you're taking the images, and then, of course, after the examination as the patient leaves. So, of course, there's two different types of communication. You have verbal and nonverbal. Verbal communication includes all face-to-face questions, two-way conversation between you and the patient. Whereas nonverbal communication is going to be when we're listening, when they're listing off concerns or histories, anything like that. And then also encouraging comments can be a form of nonverbal communication. Also, smiling, having a warm kind of personality and appearance when they first see you. Those are strategies that we can use to be more effective. So, the immediate benefits of communication. First, we want to relax the patient. This is going to reduce the chance of suboptimal imaging of the pectoral muscles. The more tense a patient is, the harder it's going to be to fully pull in their breast tissue to the board. We also want to identify sensitive breast and the reason for the sensitivity. And this can include possible rescheduling of the mammogram if needed. So, if it's the patient's menstrual cycle, anything like that, where they could have hormonal changes that make the mammogram more painful, those are options to reschedule. Secondary benefits. Of course, we want to educate the patient. We want to make them aware of what we're doing it and why we're doing it and the benefits. We want to reveal the fears and misconceptions. Rather than using the word compression is going to hurt, try using the compression will be uncomfortable. The patient will see you as competent if you meet his or her needs by explaining and maintaining that open line of communication. And this in turn will ensure that the patient is compliant during the exam. So, other factors in patient compliance. First, aiding compliance. They want to have a pleasant experience. No one wants to go get a mammogram. It's not one of those things that people look forward to. So, you want to make it as pleasant as possible. They want to make sure that they understand the mammographer. They want to make sure that they understand what is going to occur during their exam. They also want to have an informed mammographer. They want to feel confident in the person who is imaging their breast tissue. They want to know that they are taking, account for getting good pictures and trying to protect them using a shield, things like that. And then also a compassionate mammographer, a tech that works quickly and efficiently, tries to minimize the uncomfortableness of a mammogram, and ultimately, maintains that open line of communication so that there's no surprises. So some of the reasons for possible non-compliance during an exam would be a painful experience. They could be very tense and be worried about that. An unsympathetic mammographer. I've seen this a few times in my career. It's really important to be sympathetic, and imagine that it's yourself getting that exam. How would you want to be treated? And then also poor or ineffective communication. And oftentimes this stems from not describing, the plan of action or what you're doing as you're doing it. So, the vital role of the mammographer. So, there is a link between the patient and the radiologist, and that is you. And it's important that you provide appropriate clinical and didactic education. For example, if they come in and they ask, well, how often should I have a mammogram? You need to be able to reference the materials that your hospital uses for the frequency in which a woman should get a mammogram so that you can educate the patient. Also, it is our responsibility to obtain the patient's medical information to ensure that all of their information is up to date and accurate. We do have to sometimes conduct physical assessments of the patient's breast. So it's important that we know how to perform visual inspections as well as manual palpation. Especially if the patient's feeling a lump, it's important for us to know how to do a clinical breast examination so that we can properly document where that potential lesion is. And then also, we have to be able to document the findings from any assessment that we give. So, types of data collection. First, you have objective versus subjective. So, objective data collection is going to be can be seen, heard, or felt. So, for example, a lump in the breast. You can physically feel it, you can see it. Whereas subjective data collection is going to be perceived by the affected individual only. So, for example, pain. A patient may say, I have bilateral breast pain. However, that is not something that we can objectively identify. It is unique to the patient themselves. However, it should be clearly defined and documented on your forms. So, effective data collection, what can we do? Well, first, you want to ask open ended questions. This will allow for unbiased information. You don't necessarily want to guide the patient to an answer, you want them to tell you honestly how they feel. Facilitation, which is going to encourage elaboration, right? They're going to elaborate on what their concern may be. So, for example, if the patient says, I feel a lump, facilitation for you would be asking, okay, in what portion of the breast do you feel a lump? Does the lump feel hard? Does it feel soft? Is it fixed? Is it mobile? That's kind of how you can further elaborate upon those answers. Silence. This gives the patient time to remember, and to be respectful of that as they try to remember things in their past, maybe surgery dates, what they've had done, time in chemo or rad therapy, things like that. Also, probing questions, focus to provide more details. So, once again, if the patient said, I have a lump, trying to further specify is it fixed or mobile would be a probing question to ask the patient. Repetition, so rewording for clarity. This is when you would recite exactly what they told you so that they understand you understood their concern and it's documented correctly. And then lastly, a summarization, which is condensed to verify the accuracy of the entire history and exam. Okay, medical history documentation. So, of course, we want to know their imaging history. Have you had your previous mammogram here at this facility, or was it somewhere else? If it was from somewhere else, of course, you always want to have them fill out those release forms so that we can request those films. Prior mammograms are extremely important and can help to reduce your callback numbers by having those on hand. You also want to document any signs or symptoms, including palpable or visible abnormalities of the breast that you can identify. The medical history should include personal and family history of breast cancer. Specifically on the mother side of the family is the most important. You also want to know the surgical history related to the breast. So, have they ever had a mastectomy, lumpectomy? Have they had a pacemaker, anything like that? You want to know their childbearing or gynecological history because there is a link, to having kids versus not having kids if that plays a role in breast cancer. And then also you want to know their hormonal history, including the status of their menstrual cycle. And depending on their age bracket, you might want to ask if they have been through menopause yet, because that'll play a role on the density of their glandular tissue on the mammogram. Okay, so for imaging history, you want to ask where and when obtained, and you want to know any patient limitation, physical or mental. So if the patient can't raise their arm, or they're in a wheelchair, or they're somewhat kyphotic, those are all types of information that you would want to document on your patient history form. Signs and symptoms. You want to ask if there's any changes in the nipple or areola to include nipple discharge. If they do say they have nipple discharge, you want to further elaborate, is it on one breast or both? What color is the nipple discharge? Because that's very important. You also want to log any dimpling or puckering of the skin. This is really important because as breast cancers grow within the breast, they actually pull on the tissue. And so you can see a little bit of tissue retraction depending on the size of the lesion. So dimpling and puckering of skin is very important. You also want to notate any eczema or swelling, itching or redness of the skin. You want to notate any lump or lumps and also skin lesions to include moles, scars, anything like that. And they always give you a schematic diagram where you can localize. So basically, if they had a scar across the upper outer quadrant of one breast, you could draw the scar on that patient history form so that the doctor can correlate it to their images. And then lastly, you do want to notate if the patient has any pain or skin thickening of the breast tissue. Okay, so signs and symptoms, nipple discharge, just like I mentioned before. The duration, how long has it been going on for? You want to notate the color. Is it bloody, clear, white, yellow? All of those are very, very important questions. You then want to ask, is it bilateral or unilateral? Bilateral nipple discharge is far less concerning than unilateral nipple discharge. And then you want to ask if it's spontaneous or expressed. So does it come out on its own, or does the patient have to squeeze the areola or the nipple in some fashion in order for the nipple discharge to come out? For breast lumps, you want to ask them, of course, the duration. When was the first time you felt this breast lump? You want to ask when their last clinical breast exam was, or lump confirmation by physician, especially if they were seen by their primary care doctor. You want to ask about the location, and you want to ask if it's palpable. And then if it is palpable, you're going to place a BB over where they feel that lump, and that will help the doctor kind of further locate where in the breast are they feeling that lump. And then also on the schematic diagram, you would want to indicate what quadrant, kind of what clock face that potential lump was in. And then this is an example of a lump sticker. Every department is going to be different, but typically if you feel a lump, you would put the circular sticker over where the patient felt the lump. Okay, so personal or family history. You want to notate the major or minor breast cancer risks in the personal history of breast cancer. A first degree relative with breast cancer is a major breast cancer risk. So, for example, biological mom, sister, those are the most concerning breast cancer genealogic type risk factors that exist. So, you want to make sure, you ask, do you have any family history of breast cancer? If they answer yes, you want to ask, okay, who in your family and at what age were they diagnosed? Surgical history. This is another important one. So you want to ask them, have you ever had any procedures or surgeries on your breast? To include fine needle biopsies, right? Because they always leave a marker behind typically. So that'll populate on the mammogram. You want to ask if they've done an excisional biopsy. For example, retrieving a fibroadenoma. Aspirations, does the patient have a history of cysts where we aspirate the fluid? Has the patient ever had a lumpectomy for breast cancer or a mastectomy? Has the patient received radiation treatment? You want to ask, does the patient have implants? If they answer yes, you do want to ask if they are saline or silicone. You may also ask, has the patient ever had a breast reduction, as that can greatly change the density of the breast tissue as well as the nipple position as far as our mammogram images go. And then any other type of reconstructive surgery, such as a flap surgery, you want to just make sure that you ask all of these questions. If they have had a surgery and they have a visible scar, you can use this sticker down here, which is a scar marker. And basically, you would just tear off enough that would follow the line of the scar. Okay, so gynecological history. You want to ask if the patient's had a hysterectomy, you want to ask at what age. If they've had an oophorectomy, which is removal of the ovaries, you want to also ask at what age did they have that done. If the patient has had children, you want to ask at what age was their first pregnancy. And also if they're newly parity, meaning they've never had children, or the number of births of children that they've had. You also want to ask them, at what age did you go through menopause? It is considered late onset of menopause if it occurs after the age of 51. And you want to ask the age of the start of their menstrual cycles, especially if it's before 12 years of age. Okay, hormone history. You want to ask the patient, have they ever had hormone therapy? If so, what was the start date and the duration? Because hormone therapy is going to greatly affect the density of the breast tissue. You also want to ask, did they take the birth control pill? If so, start date and duration. Now, note, if you have a woman in her 60s saying that she was on not breast cancer, if she was on birth control for 20, 25 years, you would just indicate how long they were on birth control, because most of the time they can't exactly remember, the age that they started. You also want to notate any use of tamoxifen or anti-estrogen or hormonal targeted therapy drugs. For example, raloxifene. These can once again change the density of the breast tissue. So it's important to notate those with the start date and the duration that they took it. Okay, so then that brings us to patient education. How do we educate our patients and let them know, why mammography is so important? So some of the patient literature can include brochures in your department. Some places offer video and DVDs. Information packets, screening guidelines, which are normally little pamphlets that the MQSA makes, or American Cancer Society, ACR. They're just informative guides. And then also breast examination guides. So they'll have guides for breast self-examinations and then clinical breast examinations to teach patients how to do these examinations at home. So that brings us to lump sizes. So the average size of a lump found by a woman untrained in a breast exam is 3.5 centimeters. Okay. Whereas women who regularly practice or occasionally practice a breast self examination, they detect them as small as 2.5 centimeters. Women who practice regular breast self examinations usually find them at 1.5 centimeters. Patients who undergo their first mammogram, we can normally detect those breast lumps at 6 millimeters. And then a regular mammogram, we can detect them at 3 millimeters. So this is just to show you the relationship between imaging and self breast examinations. Mammography is extremely, extremely sensitive as compared to trying to feel a lump as the patient. So the breast self-exam, when is the best time to examine the breasts? Doctors say within 7 to 10 days after the start of the menstrual period, or when the breasts are least tender or swollen. Note that when you are on your menstrual cycle, that is a hormonally responsive change in the breasts. The breasts tend to be more swollen and tender. You tend to potentially feel more lesions in a swollen breast than you would afterwards. For women not having regular menstruation, the same day every month is advised to keep it consistent. So, some advantages and disadvantages of the breast self examination. So, some of the advantages include it encourages body awareness. No one knows their own body better than themselves. Actually, too, patients become more active in their healthcare. They become an activist for their own health and screening regimen. And also, it can be life saving, especially, in a young woman who is well under the screening mammogram age. A clinical breast exam is the only way to find it early on. Some of the disadvantages, of course, are the stress that it can bring, anxiety if you do think you feel something, and then also unnecessary biopsies for non malignant lesions. So, the method for breast examination. So, there's two ways to do it. You can do it in an upright fashion, standing, or supine. Upright is used to assess cancers in the upper half of the breast, whereas supine is better for assessing cancers in the lower breast. Okay, so first things first, starting with image 1. So this patient is standing upright, probably looking in a mirror, and you want to observe for symmetry, lumps, dimpling, nipple retraction, or failure of nipple erection. Okay, so this is basically where you're just trying to visualize, do the breasts look symmetrical? Does anything visually look off? Okay, then on image 2, the woman is going to lower her arms because that can change the position of the breast. So it's important to visually evaluate them with arms up and arms down. Then in image 3, this is when you're going to feel for nodes, irregularity, and tenderness both in breasts and axillary areas. And remember that in the upright position, you are evaluating the upper half of the breast and the axilla. Number 4, gently squeeze the nipple and observe for secretion and nipple erection after each nipple is gently stimulated. So this is where you're ensuring that the nipple can assume the erect position and you're trying to see if there is any type of nipple discharge that is coming out. Number 5, while leaning forward, observe breasts as they are reflected in the mirror to detect irregularity, retracted areas, nipple retraction, especially on one side only. So this is when you'd be evaluating the breast from the superior angle to see if anything looked off from somewhat of a cleavage view. And then lastly, image number 6, this is when you would lay on your back in a supine position and then you could evaluate the lower half of the breast. So you want to look for changes, like I mentioned before, indentations, retracted nipples, dimpling of the skin, prolonged skin conditions that don't go away. So, for example, eczema, unequal breasts. This is fairly common to have one breast that's slightly larger than the other. However, if it is noticeably larger, and it's a reason for concern, then you would want to get it checked out. Also, changes in texture or color, so skin thickening, anything like that, redness or scaliness of the skin, and then also any new moles or scars. So, feeling for changes. So, use of lotion or powder can be helpful. Examination in the shower if possible. They advise that you only examine one breast at a time, and you want to use the pads of your finger to apply pressure. You want to use firm pressure to assess deep lesions, medium pressure for intermediate depth lesions, and then light pressure to assess lesions below the skin surface. For the supine examination, you want to use a pillow under one shoulder. And for the upright examination, you want to raise one arm at a time as you examine that breast. So now we're going to talk about some of the methods in which you can evaluate the breast. So the first is going to be the up and down pattern. This is when you would start at the most lateral aspect of the breast. You would move your fingers downward, covering the entire breast, and repeat moving a few inches medially. So basically, you start at the lateral upper outer quadrant, you make your way down vertically to the lower quadrant, and then back up again all the way until you reach the medial aspect of the breast closest to the cleavage. Then you have the circular pattern. So this is going to once again start at the outer edge of the breast, and it uses decreasing concentric circles working towards the nipple. Okay, so basically you're spiraling in towards the areola. And then lastly, you have the wedge pattern. So this is where you begin at the outer edge and you slowly move towards the nipple and then back out towards the border. Repeating, you're going to repeat covering the entire breast one wedge at a time. So you'd basically think of it as like a pizza, and you're covering each slice by going from the crust towards, or the crust towards the nipple, and then you'd come back out. Okay, and you would do that in a wedge-like fashion until you covered the entire breast. Okay, so that brings us to CBE, which is clinical breast examination. So this is a check of the breast by a qualified health professional, normally a nurse practitioner, physician assistant, physician, and it involves looking and feeling for changes in the breast. And it also includes a check of the axilla or clavicular area for any abnormal lymph nodes. Okay, so then this brings us to American Cancer Society and some of their guidelines. So the American Cancer Society recommends that women aged 40 to 44 years old have an annual screening and a clinical breast exam if desired. Women aged 45 to 54, they recommend mammograms every year and a clinical breast examination annually. For women aged 55 and older, it is recommended that women get mammograms every 1 or 2 years, and a self breast exam and clinical breast exam is no longer recommended. Screening should continue as long as a woman is in good health and is expected to live 10 more years or longer. Okay, so if a patient is 80 years old and they're curious if they should get mammograms, basically you would want to say, if you feel healthy and you feel like you're going to live another 10 years, then yes, it would be recommended to get a mammogram. Okay, so this brings us to the U.S. Preventative Services Task Force and their recommendations. So their recommendations are that women aged 40 to 49 years old have individualized screening based on their individual risk factors. The task force recommends against routinely providing this service. They are more in the stance of your risk factors should dictate at what age you receive a mammogram. They recommend that women aged 50 to 74 years old, this is when screening would begin, and patients would receive a mammogram every 2 years. And then they do not have screening recommendations for women aged 75 years or older. And they do say that the breast self-examination and clinical breast examination are not recommended at any age. That simply screening would be sensitive enough at detecting a lesion. The American College of Obstetricians and Gynecologists recommends screening every 1 or 2 years between ages 40 and 49 years of age, and then every year thereafter. So as soon as the patient turns 50, they would have to get a mammogram every year after that. Recommendations for breast MRI. So, breast MRI recommendations are for women with a lifetime risk greater than 20%. So, that normally means that they have a significant family history. Women with a BRCA1 or BRCA2 gene mutation, or a first degree relative, such as a parent, brother, sister, or child with a BRCA1 or BRCA2 gene mutation. It's recommended for women who had radiation therapy to the chest between the ages of 10 and 30 years old, and women with Li-Fraumeni syndrome, Cowden syndrome, or Banayan-Riley-Ruvalcaba syndrome, or have first-degree relatives with one of these syndromes. MRI is not recommended for women whose lifetime risk of breast cancer is less than 15%, as it has not been proven that it increases detection rates. So, measurement of radiation dose. There's a couple ways that we do this. So, of course, first we calculate the entrance skin dose. So, this is going to be the radiation dose to the patient's skin, whereas the glandular dose is going to be the dose to the actual breast tissue within the breast. In mammography, only the glandular dose is measured because the entrance skin dose is relatively low. So, radiation doses in mammography. The entrance skin exposure for a typical single exposure can be anywhere from 8 to 12 milligray or 800 to 1400 millirad. The ACR recommends 3 milligray with a grid and 1 milligray without a grid, should be the radiation doses received. So some of the risk factors of breast cancer, the major risk factors, of course, are gender. Females are just more apt to get breast cancer. It's just proven. Also aging. The older we become, the more at risk we are for developing breast cancer. Genetic risk factors, okay? So anything that makes us genetically predisposed to getting breast cancer. A family history, a parent, a child, a brother, sister, your risk significantly increases. Also, personal history of cancer, any type of abnormal breast biopsy, and then radiation therapy has been shown to be a major risk factor. Minor risk factors include menstrual history, so depending on when the patient first started their menstrual cycle. Also, reproductive history, how many children did the patient have, when did they have children, and when did they go through menopause. Hormonal use, birth control, any type of hormone treatment, tamoxifen, anything like that. And then also DES use, which is diethylstilbestrol use, which we'll talk about more here in a minute. So, the meaning of a risk factor. Major risk factors are relatively outside of a woman's control, whereas minor risks can be hormonal related, related to the environment, or relatively within a woman's control. Having a risk factor or even several risk factors does not mean that a person will get the disease. It just means that they are more apt to get that malignancy than, say, if they did not have that pre existing condition. So, types of risk assessments. The average lifetime risk for breast cancer for women is about 12%. Breast cancer risk estimates calculate the absolute breast cancer risk, which is the chance or probability of developing breast cancer in a defined age interval. An accurate risk assessment would correctly predict average risk in a group of women with the same risk factors and age. One of the risk assessment tools used by the NCI is the Gale Model 2, which estimates a woman's risk for developing breast cancer during the next 5-year period and up to age 90 years lifetime risk based on the women's age and the risk factor information provided. So the Gale Model 2. For comparison, the Gale Model 2 will then calculate 5-year and lifetime risk estimates for a woman of the same age who is at average risk for developing breast cancer. Lifetime risk estimates are higher than 5-year age interval estimates because breast cancer risk increases with years at risk, meaning the older you get, the more at risk of developing breast cancer you are. So, gender, we know that being female is the number one risk factor. Men can develop breast cancer, however, the disease is more common amongst women. Age, as a woman ages, the incidence of breast cancer increases. So, for example, at age 30, a woman has a 1 in 227 chance. At age 40, a woman that drops down to 1 in 68. 10 years later, at age 50, 1 in 42. Age 60, 1 in 28 chance. And then again at age 70, a 1 in 26 chance. However, the overall lifetime chance of developing breast cancer is estimated to be around 12%. So, genetic risks. About 5 to 10% of breast cancer cases are hereditary. A woman with a hereditary risk for breast cancer may carry the BRCA1, BRCA2, or PALB2 genes. The BRCA1 and BRCA2 are tumor suppressor genes. They keep cancer tumors from forming. If the genes are mutated, cells will no longer die when they should, and a cancer can then grow. Family history is important. So breast cancer risks doubles for women with close blood relatives, such as their mother, their sister, their daughter, especially if the relative had breast cancer at an early age. A lot of places will base your screening protocol off when these people were diagnosed. So, for example, say you're a young woman, your mother had breast cancer and she was diagnosed at 40. Some places would recommend that you start getting screened 10 years prior to your relative who developed breast cancer at an early age. Personal history. Cancer in one breast increases the risk for breast cancer in the other. And previous cancer treatment can also carry an increased risk for breast cancer, especially treatment involving radiation to the chest, because you know that you may be harming viable tissue within the breast. Dense breasts. So dense breasts is not a disease. However, it is genetic, and often a woman will be told of her breast density after their first mammogram. Recent studies are leaning towards density being a factor in breast cancer risks in younger women. Other studies also show that women with dense breast tissue face a higher risk for missed breast cancer if the mammogram is the only screening tool used, because it is harder to visualize lesions within a dense breast. Analog mammography does not image dense breast tissue very well. However, digital mammography imaging is a more effective tool for imaging dense breast tissue. So that brings us to the BI-RADS composition categories. So the image on the left, this is going to be a category 1, which is a breast that consists almost entirely of fat. Whereas category 2, this is going to be a breast that has scattered fibroglandular densities. The fibroglandular tissue is going to be the white web-like tissue. So when you compare category 1 with category 2, it would be much easier to see a lesion within the category 1 breast than it would the category 2 breast. Moving forward, category 3 is going to be heterogeneously dense, meaning that you have scattered areas of fibroglandular tissue, and it is somewhat 50-50 of fat to glandular tissue. Then in image 4, you have, or category 4, you have an extremely dense breast where the majority of the breast is made up of that fibroglandular tissue. It's very cloud-like, it's difficult to see, and these are the patients that have the hardest time having their lesions be detected. So abnormal breast biopsy, a biopsy of atypical hyperplasia, lobular carcinoma in situ, or ductal carcinoma in situ are associated with increased risks, right? Because if you've had something abnormal growing in the breast, who's to say that those cells can't proliferate and then become something later on? DCIS is generally treated, and atypical hyperplasia or lobular carcinoma in situ are usually monitored carefully and not actively treated, depending on the extent of the disease and also the age of the patient. Radiation therapy. Radiation therapy to the chest and breast before age 30 can carry increased risks for breast cancer. The younger a woman was when she received the treatment, the higher is her risk of developing breast cancer later on in life. And that is because the breasts are hormonally sensitive, in your early 20s to 30s. That is why radiation therapy at that time is somewhat risky down the road for developing breast cancer. Minor risks include menstrual history. So starting menstruation at an early age before the age of 12 or having menopause at a late age after 55 can be a minor risk. Reproductive history, first full-term pregnancy after age 30 is an increased risk, or no children has increased risks. Breastfeeding has been shown to have a protective effect against developing breast cancer. Hormonal use, so combined estrogen and progestin therapy for more than 5 years have increased risks. And then DES use, which is women who took DES during pregnancy have a slightly increased risk of breast cancer. Also, women who were exposed to DES in utero may also have a slightly increased risk of breast cancer after age 40. And that is all I have for you.